Hi, I'm Isaac,
And I'm Faith.
and welcome
To
to
the
the
We
We
Didn't
Didn't
Plan
Plan
This
This
podcast.
podcast. So, Faith, today we're touching on something a little bit more medical and close to our hearts, about the heavy conversations that we have and about how we cope and how we learn from the things that need to be learned from. So, for full disclosure, the title of this episode, What Cadaver Lab Actually Does to You, is fully generated by Claude.ai, full credit given. But we thought it was a really nice opener because this is one of those things that we see as, at least in the literature, to be one of the first formative experience of medical school, right? But I think once you go into practice, you kind of gloss over that because I guess all our emotional and mental attention is on the patients that we actually see day to
like
day.
the live patients, the ones who we can actively help,
Yeah.
versus like our silent mentors from the past.
Yeah, exactly. And for a little bit of background to our non-medical viewers, this is often a rite of passage that you see in a lot of the TV shows as well abroad. It's one of the ways that we are taught anatomy in school, where you get the chance to interact with what we call silent mentors. They are donated bodies of the deceased that we are allowed to, use their, or to have a look at their organs, learn a little bit of anatomy, see what, certain structures and all that are like, and I suppose apply it to our clinical learning. So this is one of the first things you go through in med school. It's very early. It's year one for you as
first
well.
year for us. Yours
Yeah,
too?
likewise. So do you remember the first time you went through that experience, and what were your first thoughts?
I actually do. I remember, wow, that was like 10 years ago, I think. Yeah, so our first day, all of us, wow, white coats, it was dressed like semi-formally. I mean, those don't dress in a sloppy manner because we're going into, I think we had to recite a pledge or something on our first
I remember that too.
session.
I remember
Yeah,
that too.
so we were all just standing around in groups of 8, each around a gurney with a silent mentor on there. And then we said our pledge, and then they, unmasked, like, they revealed the bodies, and then they were like, okay, come now, this is anatomy class. Let's learn about maybe the arm today. Yeah, so each lesson will just study a different body part on someone who donated their body for medical education. Like, I mean, when you think about it from like a medical student perspective, it's like, oh wow, I've got so much to study. I need to like figure out all the names of these structures. You need to think about it in a very clinical, rational, and detached way. Versus if you think about it from a human perspective, like, oh crap, this was someone's like mom or grandma, and someone who like once had a life but now is just there forever. How was it for you?
I think the thought really hits you in and out, right? Because in this whole experience, for us, the experience was, I would say, a step more intimate than that as well, because we got the chance to actually do the dissection of the silent mentors ourselves. So we had a bunch of surgical tools, and then we would have an instructor who will walk us through, okay, if you want to explore this particular structure, like a muscle, or access a particular organ in a surgery, how they would do it is such and such. They would cut here, and then that's like the approach that you would see. And I suppose that was, if you think about it in a very rational way, that was really good for learning, because it's not the same as, like you just open a body for an autopsy and then everything is there. It teaches you, okay, like the surgical significance of certain structures and all that. And I thought it was a very good learning experience. But at the same time, I feel like when you go through that experience, sometimes the smell of the formaldehyde hits. Sometimes,
oh yes, the smell. I still remember it. Everyone was like masked up. Some people were like double masked because it was so strong.
right.
I mean, it's what keeps it's what keeps the bodies from smelling too strongly.
And you also get to, you see a little bit of blood. You see,
Yours had blood. I guess for NUS medicine it was different because, like as you mentioned, yours came like not dissected yet. Ours was already, it probably passed through a few batches of students. Yeah, so the silent mentors had been there for more years. So I guess it was a bit, not so emotionally distressing, and we were able to be a bit more detached compared to yours, where you actually had to, surgically like open them up and prepare the body.
Yeah, and I
Yeah.
think it's such a sensory experience as well, where you smell this, right? And then you look at a body that is otherwise untouched. And then I suppose now the onus is on you to do something to it. And yes, it's for a learning purpose and all of that, but it's also not a non-invasive thing, if that makes sense.
It makes sense. I mean,
right?
like, there's literally someone who's like literally us if we were no longer alive, and it's so visceral to just like cut it open and smell the blood and everything.
Exactly. And the thing is that what also felt like you start developing somewhat of a relationship is that we would have the modules across quite a few weeks, right? So from the first day where we opened it up to learn about, okay, let's say a certain part of the body, the back, then the next week it'll be another part of the body, and then you see this person every single week. And there was, I think we both had some sort of a commemoration ceremony where we write a card. I'm not sure if the families actually get the card from you, but then there was that whole ritual that you go through, and then you kind of, the gravity of it hits a little bit, and then you realize that you really respect these people for what they've given to the science and our learning.
Yeah, for sure. I mean, so how did that impact you emotionally? Like, what do you do after decompress after dissecting someone?
I felt that it wasn't really a stressful experience per se. It was more a heavy one where it really hits you that, okay, for the first time, that while this is not a person walking and talking in front of you, you're in this very particular state or in this very particular profession where you get to do some things that are otherwise very invasive and very vulnerable, right? So then it sets you on this path of slowly reckoning with the fact that you do have a responsibility to be respectful, to be, to give occasions the right gravitas that they warrant, right?
For sure.
And I guess if we fast forward a few years down the road into it, you start seeing patients and all that. Did that feeling sort of evolve? Was there a moment for you where it felt like this is more real? Because even in your clinical education, you do get to see patients, you examine them. Often it's to prepare for exams, right? But were there any interactions that slowly started to let that reality hit home for you a bit more?
Yeah, I mean, I guess the first time when you hit the wall, it's so much like sensory overstimulation. Like, as a doctor, you've got nurses asking you for things, you've got seniors expecting you to do tasks, and then you've got so many patients who rely on you to be like, their care provider throughout their hospital stay. So emotionally, it does feel overwhelming, and then some patients are sicker than others. So you've also got to, like, you're exposed to human suffering and human illness every day in the job. So you can't really afford to let yourself feel everything. You can't be like, oh no, I'm so sad, this auntie is like sick, she needs dialysis. Oh no, this uncle is like cancer. You can't be like crying for them all the time, because then you will not be able to function at work, and then everyone else at work will hate you or like just call you incompetent and fire you from your job. So it's like, how do we balance like feelings versus just numbing ourselves for the sake of efficiency? Yeah, how did you adapt to that when you started working in the wards?
It felt like a delicate balance to strike, because especially when you first start out, you're really struggling, right? And then you're getting asked 10,000 things. You're trying to not miss at least 999 of them. And then it feels like, even when someone is asking for something, patients is like, I want to go to the toilet or water. You can choose to answer them nicely. You can choose to walk away, or you can choose to say something that's very, very curt to them, right?
Yeah, it's like, oh, okay, uncle, let me get you the water. And then the second tier is, okay, I'll get the nurse to get you your water. And then the third tier is like, you just ignore or something.
Yeah, like you pretend they don't exist,
just,
right?
Yeah, pretend that he was talking to the nurse and be like,
yeah, and then all those things just kind of slip by. And I think you notice that a lot. And at a certain point, you feel like you start turning into a person that you don't really like, or into a person that you wish you didn't become. And then there's that slow adaptation. I felt that as time wore along a little bit more, then you get to focus a little bit on the actual communication and the actual interpersonal relations, which felt very good. I think about not too long ago, a month or two ago, I was in a renal ward, so a lot of my patients were on dialysis. understandably, very understandably, a lot of them are not the happiest people around.
For sure.
It's a very painful process to go through. It is a plot twist, or rather, spoiler alert, it's not something that necessarily improves quality of life, as the literature states. It generally only extends it. So actually, there's a lot of counseling you do about, whether or not they should even be on it. And when you're on it, I think it's one of those difficult things where when you're really living it, you start to feel a lot sicker. You start to feel tired. And
yeah, because they got to go for dialysis
exactly,
like 3 times a week, and they have to like go to an external center and spend hours just sitting in a chair for the rest of their lives, because if they don't, their kidneys will not function and they will not survive.
Yeah, and as a provider, I suppose, to have these conversations and to even navigate really tricky things like, we need to increase it from 2 to 3 times a week. That's one of the most controversial topics you can ever talk about to someone on dialysis, right? It really starts hitting home, I suppose, that we are in this position where I need to make sure my information is in the right place, right? I need to make sure that I'm giving it in a tactful way that respects whatever concerns that you're giving as well. And I think, ironically, also that made me feel like, okay, now I'm doing part of the human part of the job that I asked for when I signed so many years of my life away. But it's such a mixed bag. Do you ever feel like, when you've had these heavier patient interactions, the feeling that you had is not always so clear cut? It's not always like, oh, I feel so honored to be part of this. Neither is it, oh my god, I'm so sian and tired. It's probably something in between, right?
Yeah, I feel like it's a mixed bag. I mean, so in medical school, did you have simulated patients also? Yeah, so for context, in medical school, we are trained to have communication exercises with simulated patients who are basically paid actors who act out scenarios, like, for example, explaining why they need to increase their dialysis, or breaking bad news, telling them that maybe that they're not going to get better so soon, or they need to get this surgery. And then, I mean, of course, because they're paid actors, you just have to say the right collection of keywords, and they magically respond in a positive way. But
it's an exam, right?
Yeah, it's an exam, and then you do well, you communicate well. But in real life, conversations are like rarely that linear. And I mean, you say A, but you expect the patient to say B, but suddenly they say like Z, and you're like, huh, how do I bridge that gap? And how do I manage my own emotions? Or how do you balance your emotions and like the factuality of everything, and still conveying everything that you need to convey in a suitably empathetic manner? Yeah, I find it tough sometimes.
I found a really funny thing that I noticed was, I don't know how common it is for people to document their clinical interactions like this, but I noticed someone type expressed empathy as
yes,
one
I have
line.
seen that before. Yeah, definitely more than one person.
It's not uncommon, right?
Yeah, especially when you're documenting for like a family conference, which is like normally when there's more serious medical cases, you're like, expressed empathy, address all concerns, family has no further questions.
Yeah, exactly.
Like after you wrote like all the factual science stuff, then you insert a few lines of human,
yes, answer all questions all there. When I first saw that, I thought it was very, very amusing. And then I changed the way I phrase it to like, reassured regarding so and so and so. Then I just put the objective stuff that we actually said. Because I was just thinking like, was I really that empathetic?
Yeah, it's just like a checkbox that we have to fulfill, right? Like empathy expressed. Because if you're a clinician who's non-empathetic, people will be like, oh, they're so cold, this doctor didn't care about me. But if you're too empathetic, then I mean, if you cry in front of a patient, I remember in palliative care, the doctors always said you can't really cry in front of your patient, because then you're also messing with their own processing of the grief or the guilt, because they feel like they have to comfort the doctor, which is never a position a patient should be put in.
Yeah, exactly. There's so many angles to it where you're in this weird dynamic where you have to be a source of strength, but neither can you overpromise the strength, and neither should you ever underpromise the strength. And you have to sort of deploy vulnerability and show it in just the right amounts, right? Because at the end of the day, we are human too. I'm sure you've seen patients that reminded you of your own family, or that really hit very hard, right? I think the closer in age the patient is to me, the more difficult it is. I remember overnight on call, I attended to a young guy in his 30s who I think had a stroke. And then
oh my gosh, that's scary.
I didn't attend to the stroke, thankfully. But then it was just a very routine, take bloods for a fever kind of thing. And it felt like as I was doing it, it was this at once terrifying, sobering, and very sympathy and empathy inducing experience to kind of hear this guy. It was quite a bad stroke as well, so he was like semi talking to me, but also it wasn't it wasn't fluent, and the deficits were pretty
so like just
serious,
half of his
right?
body whacked out,
Yeah,
not able
correct,
to move,
correct.
and he's just like around our age.
Exactly.
It's so scary. It could be us,
right?
Yeah, and I think that's what makes it like scarier, and like the empathy level just goes up when we relate to it even more.
Exactly. And then like it then spikes again if it's an elderly person who reminds you of your own grandparents, or they talk to you the same way, and then you see those little, it like kind of exposes a bit of chink in the armor from time to time. And I think it's something all healthcare providers are exposed to in some degree. Are there any ways in which you process the heavier conversations? It can be the more angry ones, or the sadder ones, or the whichever.
Yeah, I feel like it's easier to process like angry conversations, or like when patients are just very heated or emotionally charged or distressed, because I mean anger is just like misplaced emotions or misdirected emotions. They are probably also stressed, but once you figure out what they're stressed about or what they're freaking out about, then actually the conversation gets better. Or if they're just plain unreasonable, sometimes it's just like, okay, never mind, water off a duck's back, move on. But like breaking bad news to patients, or like watching seniors break bad news, like, oh, this person has a stroke, or the person didn't make it, or has a stage 4 terminal cancer diagnosis, is like, I think that's a lot. It's a lot harder to sit with and to process, because you know how final it is. And no matter how much the clinician might explain the diagnosis to people, sometimes they still have hope. They still have hope, but you yourself know that, oh no, this guy's like not going to make it more than X months, and then you just have to silently carry that with you while you continue treating the patient, knowing that it's like you never know when it's going to be the last time you see them alive.
Yeah, and there's the whole concept that we call pacing with people, right? And it sounds like such a clinical off the cuff kind of word, but in reality, it's especially if you're in the same ward with the same patient all the time, and you're on the phone with their family every single day, and you're slowly together with them coming to terms with the reality that there is a number to the amount of time you have left, right? It just feels not easy sometimes. And I don't know, I feel like the way that we process it collectively in a team, right, or as your friends, it's like it's enough but also not enough sometimes, in the sense that you'll tell your colleagues, like most of the time it's not like people will ever brush you off, right? Like you'll say that, like, oh my god, like this ama is so sad, this and so happened, and then you just kind of share the medical facts with your friend and share how sad the family members were, and then it's kind of a moment, but it's normally like a 10-second moment.
It's just very brief, because I mean you can't like spend like an hour talking about every single patient, because there's too many like that already. Maybe we're a bit desensitized, right? Also, to some extent.
And I don't know whether it's a good or bad thing where it feels so far adequate also. Like, I'm sure there will be times where we encounter much more severe and much more weighty scenarios. We're both quite junior in our careers as well. But then sometimes I wonder, am I a very different person going into this than I once was? I remember I wrote in my medical school personal statement, right?
Wow, that's great.
There was this like very tear-jerking, heart-stopping moment where I was doing some volunteering thing, and then I gave some patient medication instructions, and they were very moved by it, and it was like some very simple act that
you managed to dramatize it a lot.
And it genuinely felt like at the time it was such a big moment for this guy, and I was like, wow, I feel like so privileged and empowered to be in this position.
You've made such great meaning in his life, and then versus like us now is in everyday occurrence.
It's like you can talk to someone about metastatic cancer between your morning coffee and your lunch, right? And I'm not saying that we do our best to do it in the most tactful and in the best way possible, but at the same time, sometimes you are real with the fact and recognize the fact that actually inside you're not exactly in this place where this is like such a thing for you. You do your best, you do a good job out of it, and that's perhaps the way to be sustainable, to deliver good care all the time as well. So that's something that I think we're all navigating right now, right?
Yeah, I mean, I guess it's unavoidable. I mean, healthcare, working in healthcare itself is not a normal thing. Most people are not surrounded by this amount of, illness, emotional distress, suffering, and death on a regular basis. So healthcare workers, we're in our own little bubble where this is normal for us, but to everyone else, it's like, oh, this is the worst day of their life. But for us, it's just, oh, it's just another day, and it's just another patient who's sick. Yeah. So I guess the perspectives are also very different depending on like whether you're on the patient side or the healthcare side.
Do you think anything in the course of school or training really prepared you for this? Or at least do you think what training was given was enough?
I don't think they really train you specifically for this though. Like they train you to handle all the the intellectual side of things and the practical side of things. You're trained how to restart a heart, how to defibrillate someone, how to intubate them, but not necessarily how to deal with your own emotions, your own emotional regulation, stress regulation, and just coping with the fact that your patient might just conk on you in the middle of a call. Yeah, do you feel like your medical education touched on that?
It feels like it did and didn't at the same time, in the sense that there was so much emphasis placed on communication, there was so much emphasis placed on understanding patient journeys. I think there was one time where they brought in a patient to also share her own journey recovering from a stroke, things like that. I thought those were really good experiences. And then I think the marking rubric in our schools is a bit different also, in the sense that they did mention, I think some of our tutors are common across schools. I think they were saying that at least for our curriculum, they try to do away with some of the marking rubrics for the communication, so we don't have to, or rather we're not obliged to say certain things when it's not the most accurate or appropriate. Then it's a little bit more, they spend a little bit more time coaching us on like, actually in this context, in a very real sense, your tone was a little bit off, like you smile a bit too much, smile a bit too little. I thought those were really good.
Yeah, those are really good tips though.
Yeah. I mean, one of the things I got was that I smile a bit too much, which I think is very fair. I'm a very smiley person outside the hospital. For many other reasons in the hospital, I don't smile as much. And that's not because I'm deliberately trying to be serious.
Relatable.
But I think what it doesn't prepare you for is the circumstances in which you need to tap on those communication skills, where it is the 10th time in that day you have to do it, or it's 4 a.m. and you barely feel like you want to do anything, let alone be a part of a heavy conversation. But the patients don't take what time, they deteriorate. And you just go into it, right? And it's more of like, I don't know, I'm thinking, we should suggest to the faculty 1 or 2 of these classes should be they make you like stay up overnight and then have a camp. Then you do the session to end your overnight stay at 5 a.m.
Yeah, you do both practical tasks and emotional tasks.
Exactly.
And see how you feel at the end of it.
Exactly. Like you go and like take blood from the mannequin, and then after that you cleaning up the mess, you go and call someone.
Yeah, and then you have to call someone and say, oh, your father's not doing too well, his oxygen saturation is bad, you should come and see him at like 3 a.m. or something.
I think that's really the crux of it. So I mean, I guess if we move away from the purely medical circumstances, it's a really heavy thing, and it's something that we're continuously working on, in no matter what setting we're dealing with patients, right? Moving on to the more interpersonal and interprofessional level, I think that's a more interesting one, where your co-workers are figuratively but not literally dying. But I would say that the way that we interact with each other, I think the desensitization in general also trickles into it. Do you have any thoughts when I say desensitization and interacting with your colleagues off the top of your head?
I feel like everyone sort of developed some form of dark humor to cope with things. They're just like, oh, this guy is like dying, and then the other patient is also, like a rock or something. Yeah. I mean, in context, should we explain this context or not?
I don't know if we should.
Yeah, but I mean, basically, we are happy when a patient is we're happy when a patient is more like a rock, because it means that they're stable and they're well, which means there's nothing new to do for them, which is better than a patient being really sick and us having to take bloods for them every day because we'll be really worried about those. Yeah, so actually we're happy to have rocks. Yeah, I mean, these are all just like coping mechanisms that we develop. It's not that doctors are being insensitive. It's a lingo that we've adapted into. To an outsider, it might sound cold or rude or confusing, but to us, it's just like, okay, this is like, our daily life. It is what it is.
Yeah, and I think the other way that it sometimes comes across might be, it feels like you have a lot less emotional bandwidth to, if you draw a parallel to other professions, right? People complain about, sometimes their co-workers are like fake nice to them. Like you mask, or your superiors, they mask things with corporate speak, and then they you decline your leave on a velvet glove. But I feel like, for better or for worse, what I'll say is that there's no fake niceness, because there's not that much niceness, period.
Yeah. If people are nice to you, it's pretty genuine. Like, no one's gonna be like, I'm gonna coddle this person because I want to have a good reputation. People are just like exhausted. So what you see is what you get. If they're nice, they are like uniformly nice. If they're mean, they're also probably uniformly mean or sleep deprived.
Yeah,
which is fair.
And I think when you get refused things, there's no velvet glove. It's just
like
you cannot take leave. Sorry. I don't think there's a sorry, actually.
Yeah, there's no sorry. They're just like, oh, you cannot take leave. Just pick another week. Yeah, you can't book your trip. You can't do this. You can't do that.
And do you feel with this tone or this tempo of interaction, sometimes you must code switch when you go outside, whether it's in your personal or even your professional interactions outside? I feel that I have to sometimes.
Oh yeah, I mean, we definitely have to code switch even among the like hierarchies. Like to a fellow house officers or medical officers, you can probably like shoot the shit, even a registrar. But around your consultant, you can't go around like being so informal or casual or making dark humor jokes. Yeah, because they probably think less of you. And I mean, in front of patients, obviously not. You can't even. I mean, oh yeah. So I think there was once where someone made like some dark humor joke, but the patient's family was nearby. So no. I mean, they didn't hear it, but we were like, oh my gosh, it pulls them away, Yeah. So you have to be careful because everything is within earshot of like someone who could hear it and take it the wrong way.
For sure. And I think you also then have to tune the frequency or the courteousness a little bit, right?
Yeah.
I mean, I have a really vivid memory for one of my postings in a specific department, in a specific hospital, where I was quite new, like weeks into the job then. And I think at that point, basically what I was doing is that there was a patient and they had to go for kidney dialysis in the inpatient dialysis center. I didn't forget anything. It's just that the superior or the senior wanted to make sure that they went for a morning slot so that they can do something in the afternoon. I forgot what it was exactly. And then I mentioned, okay, I called them to book an appointment or make sure the name is in, and then they didn't reply, I'll call later. And this senior got very, very frustrated, like visibly frustrated. And then she said this, like she said that you are not here to learn, you are not here to make decisions, you are just here to get things done. And then she marched me to the dialysis center
to book the slot.
And how she did it was that she went to the counter, she snatched the book away from the patient service associate or the nurse who was like kind of like, I think she was like there. It wasn't like in her hands but it was there. Like, and then she just pulled it over without saying, sorry, can I take a look at this? She opened it and then she just like shouted she didn't shout, but she was like, is this patient in the morning slot? And then the nurse was like, yeah, God,
calm
down,
calm
down. Yeah, and then it kind of, that was probably, I think, a more extreme situation. It's not very commonplace.
Yeah, it's not common.
But I think it really emphasized to me that, okay, yes, like part of me is sympathetic that this senior of mine probably has not slept very much and whatever, but it also emphasized to me, like when I go out, I should probably not treat people like this. And when I have juniors next time in the medical system, or when I have juniors right now outside, I try not to do that. Sometimes you see examples like this that really hit home as well.
Yeah, I mean sometimes you see like truly shocking ways that like doctors or other people treat the nurses. And I mean, that doctor probably thought that she would. I mean, that doctor was doing good for the patient in terms of, achieving the objective of getting the patient that slot. How the doctor went about that was a bit, a bit concerning. But Well, I guess emotional regulation is difficult sometimes when you're running on like a high stress job, poor sleep, and I don't know.
A lot of things.
Yeah, a lot. There's always so many things going on in like a
things.
senior doctor's mind, because they've
A lot of things.
always got like research papers, surgeries, procedures, people to answer to, families to speak to. Yeah,
And for the mid-level people, there's always someone on their back.
Yeah, there's someone above you and then people below you asking for things.
Yeah.
Yeah, it's a stressful job all around. Yeah, I feel like we have to numb ourselves a bit to some extent. Do you feel like you've had to numb yourself, like, you know, since you started work? Like, in fact, if you had to give a percentage, or like, you know, how numb?
I think numb about 80%.
Probably
I think
same.
80% is my ballpark.
Yeah, because like if we feel everything is like, we'll just be
Yeah.
so stressed and so sad for all our patients every day.
Yeah, and I feel like being invested in it in a very genuine sense, or rather over invested in it, takes away your bandwidth to do the same for the next guy, and the next one after that, and the next one after that.
Correct, because like you only have like maybe like 100 units of like emotional.
Yeah. This is like a bit of a dark humor already, but I was like thinking, you know, sometimes you would have mornings where, especially in certain departments, you have to talk to maybe 3 to 4 families whose family members have a really bad cancer every morning. It's like you barely can remember who has what cancer, you know what I mean?
Yeah, it's true. And like you have to refer to the paper.
Exactly. And then if you're like too sad about it, it's like I would have to take a break from it and then go to the next one. And then that means by the time it gets to the third one, right, then you don't even, you might not be able to deliver whatever you
you'll
need
be
to
like
deliver
emotionally spent and mentally spent, and your time was also just gone. And I guess patients also sort of expect doctors to be, you know, the rational and calm ones in times of crisis. So if we are like too emotional, we'll also get criticized. So it's like you can't really win.
I think the best seniors I know, or at least the ones I try to emulate, are the ones who are able to, for lack of a better word, manufacture a little bit of the emotion in healthy doses. You know what I mean?
Microdosing it.
Exactly. Like like sometimes you see really glaringly bad examples of cold communication. And you don't want to go there, but neither do you want to be, you know, like I've seen some colleagues or fellow juniors who are really very invested to the point where it's unsustainable. Like
where they're like, when they get stressed and they stay back late on purpose just to check the patient's results and check on the patient, and they can't leave work because of that.
Exactly. Then you wonder, you know, like if you go to a tougher posting, then what now, you know?
So speaking of like leaving work and leaving your work behind, do you feel like you sometimes carry some of that emotional numbness and desensitization home, like to your personal life, or like interactions with friends, family, or whatever?
I think I've definitely found myself guilty of that, especially in a more professional context, like when I talk to my partners, my colleagues, or whatever, my clients outside. Okay, less so clients, but probably to the people who work alongside me. I do notice that I take a lot of like the way we talk to each other in a healthcare setting outside, where I say, okay, let's get this done, 1, 2, 3, 4, and then I just kind of leave it at that, you know. It's less of a, if you have the time, do this, could we do that, you know. And then you sometimes catch yourself, and I suppose at the end of the day, to me it feels like, well, actually there's a mixed bag to this, right? The way we communicate in healthcare, I feel actually it's very effective, you know.
It's very efficient. You get straight to the point. You outline what needs to be done. It's like you don't need to sugarcoat them and be like, oh, you were great today. If you have time, can you do this?
Exactly.
Oh, I really appreciate this.
I think SBAR should be something that is like taught at uni, you know, to every course and every
so SBAR is like the way you hand over cases. It's very clear cut. You just explain the background and the assessment and like what you're doing for the patient.
Exactly. Like for people who do this, for people who don't know this, quickly, it means situation, background, assessment, recommendation, right? So it's like, oh, I need to get this proposal done for someone by this day. It's already been, you know, it's 3 pages in, but then I just need you to tidy up the final bullet points, run it through the AI once more. I would probably recommend that you use this AI and check with this other person if you're not sure, Ken. So it sounds it's such a great frame to think about.
It's such a nice, tight, concise plan. Like, But I guess people will call
yeah,
us too clinical or like too
exactly,
cold, right, in the
exactly.
outside world.
So the hope is that you can package some of the
Mm.
good bits of what we learn and try to mitigate or maybe cushion it with some of the other not so nice tendencies that might be excusable, that might be not excusable in a situation with less medical urgency. And yeah, I guess you find your communication style outside of that. How much of that do you leave at the door?
Oh my. I don't know. I feel like I end up, because I mean, in the GP clinic, every day I'm just telling people, okay, it sounds like you've got a flu. Let me just give you these medicines. So my brain, even when I leave work, sometimes I'm just subconsciously just, telling people what's best for them, or like what needs to be done, or like, feeding them like the name to their problem or their feeling before they've even had time to process it themselves. So I do wonder if it makes us more like paternalistic in a way. Like we're just like, okay, you have this, therefore you need to do this because it's medically indicated. And then in the personal life, it might sound like, okay, you're like eating too much or something, I don't know, or you're not taking good enough care of your health. You need to do this, this, that. And then to the people that you're talking to in your personal life, they'll be like, no, why are you telling me to do this? I don't want to do this. But it's just an occupational hazard, I guess, sometimes.
Yeah, I think there's a lot that one digests and one processes, and we all find our balance at the end of it, right? With all this in mind, is there a particular moment or a particular feeling or perhaps era in this whole journey that really stuck with you, even if it's not individual patient interaction?
Like an interaction that made me think that, oh, I need to compartmentalize.
Or no, something that just maybe really set the tone for what kind of a clinician you want to be, or that just stuck in general.
Oh, I think it would have to be like when I was in my internal medicine posting. There was, I mean, it's back to dialysis patients. Yeah, so there was this guy who came in with kidney failure. I think he was in his 50s. He wasn't very old. So actually, he could have had some road to live on if he had chosen dialysis. But the thing is, we sat him down for a family conference, explained everything in great detail to him and his family multiple times, and he was still like, I don't want dialysis. I just want to, pass away naturally. I don't want to lead a life where I'm being forced to do this just to survive because there's no quality of life. So I think it's in those kind of things, these kind of situations where one part of you is like, but medically it doesn't make sense. You should do what's good for you, but at the same time you have to respect the patient's autonomy. Even though you're like, why are you doing this? This is a waste of your life. Like we can save you, but you're not letting us save you. So like you can't afford to get too emotionally invested in such cases, I suppose, because if not, it just feels like or why can't they see what's best for them? Yeah, so you just have to leave your feelings at the door in such a case, I guess.
Yeah, I think we all have that one or two interactions, right?
We've all had this.
I have this actually similar situation, dialysis related also.
Yeah, that dialysis patients somehow really cause a lot of emotions.
Right. I had this also internal med, but there was this lady who had to go on temporary dialysis for for a certain very urgent build-up of toxins in the body, that kind of thing. And the hope was that she would get to go off it, but it didn't look very good. Background was that this auntie was, as they say in the UK, they like to use this term which I've seen on TikTok sometimes, called pleasantly confused.
Oh.
She was very pleasantly confused. So it's those like really cute aunties who have no idea where they are, but they are very smiley and very lovely. And then miraculously, she actually took a turn for the better after about 2 weeks. We already had a conversation to preempt them that the dialysis will have to stop and it would be terminal. But somehow she did a U-turn and she went from just like being in the bed, looking very, very weak, to standing up, and like she gave us the Korean hearts.
Oh my gosh! I mean, wouldn't we love to see that?
It was
like,
so adorable.
Miracle.
And then we were like, okay, she's like 2 days away from walking out of the hospital on her walking stick, right? And then there was a complication. So it was a surgical complication also. She started, there was like a bit of a bleed, and then after that we didn't know why, went for scope. There was a further procedure she had to go for, and then it was one big U-turn. So we saw her go from smiling and giving us big heart shapes to being very, very sick again. And then I think that really stuck with me because I knew the family throughout this process. The patient went up to a different ward also, but then I think it was just it was probably one of the few times where, because each patient encounter most of the time is very fleeting. It's like 1 or 2 day thing, and normally either it's fully downwards or fully upwards, right?
Yeah, it's not
Yeah.
up and down. It's just like playing with our emotions also.
Exactly.
You just really want to root for your patient. You're like,
Yeah.
yes, please get better. Like, get out of hospital. I want you to, recover. And then suddenly, when you guys thought things were turning around,
exactly,
like it's right in the feels.
Right in the feels. So I mean, we all have that person that we remember. I think everyone who's in healthcare listening to this has a person or two or a family that really stuck with them. And I mean, with all of this, today we talked about the living and the previously living and how we've carried that throughout this career, many more years, where we will get to slowly and fully, maybe not fully, not even close to fully, uncover the full spectrum of human experiences, which I suppose we're all looking forward to with cautious optimism at the end of it.
Yeah, I guess it's all just about learning how to strike a balance between, being a sufficiently empathetic doctor, but also not letting all those emotions overrule your clinical judgment and ability to be professional. So I guess that's it for this episode.
Yeah, here's to better communication, better feelings, and learning and growing. See you next time.